Good day viewers. Today we are going to see about another enzyme in the series of isoenzymes, creatine phosphokinase, which is shortly called as CPK. Let us get into the lecture. Creatine phosphokinase is also known as adenine triphosphate creatine N-phosphotransferase. According to the nomenclature of enzyme, it is numbered as EC 2.7.3.2. It is a dimeric enzyme of molecular weight 82 kilodaltons. The normal range of this enzyme in the serum is around 4 to 60 international units per liter. It catalyzes the conversion of creatine to creatine phosphate. It consists of three forms of isoenzyme. Each isoenzyme is a dimer of molecular weight 40 kilodaltons. The subunits were derived from chromosome 14 and chromosome 19 for the heart form and the muscle form respectively. The graph represents the level of tissue localization of creatine kinase, where creatine kinase is highly found in the skeletal muscles. So this is the overall reaction catalyzed by creatine phosphokinase. It shuttles the inorganic phosphate between ATP in the mitochondria and to the myofibrils present. So ATP is the donor of inorganic phosphate for creatine. By taking up the inorganic phosphate, creatine is converted into creatine phosphate. This is a reaction catalyzed by creatine phosphokinase. As we have already said, it has three isoenzymes and they can be electrophoretically separated into CPK1, CPK2 and CPK3. CPK1 is called as BB form, CPK2 is called as MB form and CPK3 is called as MM form. CPK1 is mostly found in brain and lungs, CPK2 is found in heart, CPK3 is found in skeletal muscles. This enzyme is unstable in the serum. Its activity is lost due to sulfidyl group oxidation at the active site. It is a dimer where each dimer is made up of 41,000 daltons. So these are all the three different forms of isoenzymes, their electrophoretic mobility and the percentage of enzyme present in the tissue. And they will be elevated during various diseases like CNS and acute myocardial infarctions. Coming to the clinical significance of creatine phosphokinase. Creatine phosphokinase is highly associated with heart attacks and muscle diseases. CPK2 isoenzyme is very small. It is only 2% of total CPK activity and it is undetectable in plasma. Whereas in case of myocardial infarction, the levels increase within 4 hours, then they fall rapidly. The total amount of CPK level elevated will be around 20 folds in myocardial infarction. In case of muscle diseases, it is elevated in the range of 500 to 1500 units per liter, and it is highly elevated during crush injury, fracture and acute cerebrovascular accidents. Estimation of the total CPK is applied in muscular dystrophies and CPK dystrophies. The CPK-MB isoenzyme is estimated in myocardial infarctions. Apart from the three major isoforms of creatine kinase, we also have two atypical forms which are not normally found in the plasma, but they are found in minor population with certain issues. It is macro CK. This is formed by aggregation of the MB form of creatine kinase with immunoglobulin IgG and sometimes with IgA, also formed by complexing with your MM form with lipoproteins, and their electrophoretic migration shifts between CKMB and CKMM. This occurs in women above 50 years. The next atypical form is a mitochondrial isoenzyme, where it is present bound to the exterior surface of the inner mitochondrial membrane of the muscle, liver and brain. It exists in the dimeric form and aggregates into oligomeric form. The molecular weight is 35,000 kilodaltons and the Electrophoretic mobility migrates towards cathode and it is behind CK-MM band. It is not present in the normal serum. Clinical significance when CK1 form is elevated. It is very low during in the kids of low birth weight newborns. In case of brain damage in neonates, neurological injury. This CK1 rise in CSF is greater than 200 units per liter, leads to death of the patient. If it is in the range of 100 to 200 units per liter, there is a survival chance with a neurological defect. When it is lesser than 100 units per liter, there is a good chance of recovery. And it is also increased in the adenocarcinoma of GI tract, in various other cancers like lung, prostate, bladder, testis, kidney, breast, ovaries, uterus, leukemia, lymphomas and sarcomas. It is present in serum when there is extensive tissue damage causing breakdown of mitochondria and cell wall. Its presence in serum indicates cellular damage. It is seen in malignancies. CK2 is elevated during myocardial infarctions, head injury, subarachnoid hemorrhages, exercise, and CK3 is found during muscular dystrophies, myopathies and hypothyroidism. In case of muscular dystrophy, you have higher fold of increase, whereas in hypothyroidism, 5-fold increase of CK2 is observed. Thank you for your patient listening. Let's get back with another interesting isoenzyme which is used clinically for diagnosis of disease.